This conference will now be recorded.
I can go ahead and get started. So we're going to talk today about ventilatory support and management. I'm Beth Carpenter. I'm one of the brand new PGY2s, and Dr. Johanigman was kind enough to mentor me through the lecture. This is a very large topic, so we're going to really try and focus on some set key objectives which SCORE laid out for us. The first one being able to understand modes of ventilation and discuss the physiologic and pathophysiologic consequences of that ventilation. The second is to discuss factors that contribute to abnormal physiology after surgery and who's at increased risk for severe post-op complications, specifically as it relates to respiratory failure. Third one's very broad. We're going to touch on why and when mechanical ventilation is indicated. The fourth is we're going to step through appropriate post-intubation mechanical ventilation settings to start and discuss kind of a troubleshooting algorithm when those are ineffective and you need to make adjustments. The fifth is recognizing esophageal intubation. We'll discuss that. And the final one is touching upon what's involved in weaning for mechanical ventilation. Prior to discussing the modes of ventilation, I think we should be familiar with, I wanted to discuss the two basic main types of ventilation, and that's volume control versus pressure control. In volume control, we can see, I don't know if you can see my mouse, but in volume control, flow and volume are fixed, whereas pressure changes, which you can see on that second bar down on the chart. Whereas in pressure control, pressure is fixed and volume changes. And I think this is a key principle to bear in mind as we go forward. There's different variables that you set in each. To avoid kind of going into the weeds, I think we'll just bear in mind that there's two settings that affect oxygenation, and that's your PEEP and your FiO2, positive end expiratory pressure and fraction of inspired oxygen. And there's two buttons that affect your ventilation, and that's your tidal volume or TV and your respiratory rate. And you can see that you effectively set these in both of those. And those are the two variables to bear in mind as we discuss the two modes of ventilation that we'll focus on today. And that's assist-controlled ventilation and synchronized intermittent mandatory ventilation, or AC and SIMV. So assist control has two types of ventilator breaths that we see in the chart. A spontaneous breath, which is triggered by the patient, and you can see here it's triggered because we see this negative pressure deflection from the patient's own inspiration, and a time-triggered ventilator breath that was initiated by the ventilator, which doesn't have that negative pressure deflection. Importantly, in AC mode, both of these types of breaths are fully supported by the ventilator. Meanwhile, synchronized intermittent mandatory ventilation, again SIMV, allows unsupported spontaneous breaths by the patient, while also having supported ventilator breaths to reach a set total minute ventilation goal. And you can see there at the very bottom that there are some that are fully supported by the ventilator and some that have a smaller tidal volume that are initiated by the patient. There's a couple other modes that SCORE wanted us to be aware of that I'm really only going to touch on today. That's controlled mechanical ventilation, which describes a mode where minute ventilation is determined entirely by the set respiratory rate and tidal volume, and there's no patient participation. So this could be immediately after pharmacologic paralysis with heavy sedation, a coma, etc. There's pressure support ventilation, which describes pressure augmented spontaneous breathing, where the patient controls inspiratory time and tidal volume. And this mode I've seen be very useful during vent weaning, specifically at low pressure, so about 5 to 10 centimeters of water support to overcome the pressure of a vent circuit. There's some nuances, but the way that I kind of think of this is almost as if it's invasive BiPAP. And then finally, airway pressure release ventilation, or APRV, is a mode which employs prolonged periods of spontaneous breathing at high end expiratory pressures, so around 30 centimeters of water, which is interrupted by brief periods of pressure release to atmospheric pressure. And this is kind of like a high pressure CPAP. And this mode is useful in alveolar recruitment and preventing further alveolar collapse. You're not handcuffed to a single mode. So Dr. Johannemann pointed out yesterday that you can really think of CMV to AC to SIMV as a spectrum of patient participation in the ventilation. And you can change modes as a patient's clinical condition changes, and in some situations that would actually be clinically indicated. So just because you start a patient on a mode doesn't mean that they need to stay on it for the duration of their ventilation time. And each of these modes have their own characteristics, their benefits, mean airway pressures that contribute to hemodynamic effects, all things to bear in mind when a patient's being ventilated. And it's also important to remember that mechanical ventilation isn't free. So there's multiple adverse pulmonary effects to positive pressure ventilation. Those include barotrauma, volume trauma, atelecta trauma, biotrauma, and then things outside of the lungs. So ventilation is associated with increased risk of GI stress ulceration, and it promotes a large inflammatory cascade that we don't even fully understand. So there's risk to ventilation, which is why a patient needs to be ventilated for the time that they need, and then you should work towards weaning and getting them off the vent. Our second learning point focuses on being able to discuss factors that contribute to abnormal pulmonary physiology after an operative procedure and identify those of our patients who are at increased risk for severe complications. So loss of functional residual capacity postoperatively can be from a variety of factors. And as a reminder here, I put in our volumes and capacities in the lungs, and that functional residual capacity is the summation of the expiratory reserve volume and the residual volume, that volume that doesn't participate in gas exchange. So there can be factors that are intrinsic to the patient, or things that the patient has had. They could be obese, they might have an advanced age or a strong smoking history with COPD, or things that we have interacted with a patient, specifically abdominal distension, whether or not they have a painful abdominal incision, if they've been placed supine for a prolonged period of time, or if they've been volume resuscitated and that's contributed to volume overload. Those can all put patients at increased risk for having pulmonary complications postoperatively. The third learning point could be its own talk for multiple hours, and that's when and why mechanical ventilation is indicated. We won't spend too much time on it, but ventilation is indicated for acute or chronic respiratory failure, which is either insufficient oxygenation or insufficient alveolar ventilation, or it can be a combination of both. Some common indications for ventilation include a depressed mental state. We'll see that in the trauma bay, inability to clear secretions, etc. But that's really the extent of what I want to cover on that. Our fourth learning point focused on, in an emergency patient, being able to select appropriate post-intubation mechanical ventilation settings, bearing in mind that this is a moving target and you're going to be making multiple adjustments over the patient's clinical course. We'll also talk about common reasons why your vent settings might not initially work and some troubleshooting through that. So I'll offer up the ICU Blue Book's recommendation for initial vent settings. The books suggest starting with AC as that initial mode. Again, AC is going to deliver a full ventilator breath to each breath, even that the patient initiates. We'll select a lung protective ventilation tidal volume of 8 millimeters per kg of predicted body weight, which is dependent on the patient's height, and you can Google this. And then we're going to work on weaning this down to lower tidal volumes to help prevent against volume trauma. We're going to use an IDE, or inspiratory to expiratory ratio, of 1 to 2, which is fairly standard. We're going to choose a respiratory rate to match the patient's spontaneous respiratory rate, or if they don't have one, a rate to match our prediction of their minute ventilation requirements. So this can be between 16 and 18. We're going to set initial PEEP, or positive end expiratory pressure, at 5 to prevent collapse of distal air spaces at end expiration. And we'll set our initial fraction of inspired oxygen, or FiO2, to 100%, and we're going to work on weaning that down. If FiO2 greater than 60% is consistently required to maintain adequate oxygen saturations, and that hypoxemia is refractory to oxygen therapy, we may need to have a higher PEEP. And that goes back to our two factors that contribute to oxygenation, which is PEEP and FiO2. But things to consider after you place a patient on the vent: why are they not improving, or what are some common causes of acute decompensation of the mechanically ventilated patient? So this is an algorithm that I borrowed from UpToDate. This is by no means the algorithm, but I think it illustrates some key principles in troubleshooting when you're having some issues with a mechanically ventilated patient. So we'll start at the top here, where you have a patient in the emergency department or the ICU or wherever who develops respiratory distress or new hemodynamic instability, and they're being mechanically ventilated. So first step is call for help, but the second step would be to disconnect the patient from the ventilator and begin to ventilate manually as you start to work down your algorithm. If this helps, it may be that there was a problem with the ventilator or the settings. So you'll work on solving that. But if the patient continues to deteriorate, you want to start identifying the reason why. Life-threatening causes: do they have a tension pneumothorax that needs to be decompressed? Is the endotracheal tube actually in the trachea? Has it been displaced, or is it obstructed? We won't get too into some of the rest of those because I think that's getting into the weeds a bit. And then you're going to start to assess: is the patient difficult to ventilate? Are they difficult to bag? If they're not, you can begin to see if the endotracheal tube has a plug or some sort of obstruction, so you can attempt to pass a suction catheter. If it's difficult to pass, the patient may be biting on the tube. They might need more sedation, or the tube might be kinked itself and require replacement. If it's able to pass freely, you might start to identify that this might be an intrinsic lung problem. So they may have developing ARDS, some other compliance of the lung issue, and you're going to need to address that, likely with medical intervention. So I'm just going to take a step back here and just reiterate the points are: if you're having problems with a ventilated patient, start off by keeping it simple. Is the problem your circuit or your vent? Is it outside the tube and something like a tension pneumothorax? Or is it in the tube, or is it in the lungs themselves? And those are really the things to focus on as you begin to troubleshoot what might be occurring with some sort of decompensation. Kind of related to this is our fifth learning point, which is recognizing esophageal intubation, which is very important. So end-tidal carbon dioxide determination is the most accurate measurement of confirming endotracheal tube placement in combination with listening and auscultating and hearing bilateral breath sounds. Some other common suggestive indications that you have a proper tube placement that you'll hear about are misting of the endotracheal tube or a chest x-ray. These are both findings which may fool you. A chest x-ray may show you what appears to be a properly positioned tube, but it could be behind the trachea and the esophagus. So these can fool you. Even visualization of the endotracheal tube through the cords can't be used to confirm placement, and I've seen this asked in some of the practice questions. So you're going to be looking for evidence of end-tidal CO2, and this should be used in every intubation. Be aware the esophagus may have small detectable amounts of carbon dioxide during the first few positive pressure ventilations. So you're going to want to see evidence over multiple exhalations of positive color change before you can safely conclude that the endotracheal tube is in the trachea. And bear in mind, just because it was initially in the trachea doesn't mean that it can't dislodge. So this is something that you should be considering even down, your pathway of a displaced endotracheal tube. And I'll just reiterate right now that in all of these situations, especially when I was in the new intern's shoes a year ago, don't be afraid to call for help if you're having any of these problems. This is not a one-person job to troubleshoot this. This requires multidisciplinary assistance. And then our final learning point is understanding what's involved in weaning from mechanical ventilation. There's a variety of philosophies regarding who's appropriate for weaning from the ventilator and some set criteria, as well as figuring out who's appropriate to undergo a spontaneous breathing trial. Things to consider if a patient's ready for weaning are the following points here, bearing in mind that some patients won't satisfy all criteria for any of these things I'm about to discuss, yet they'll do very well weaned off ventilation. So we first want to consider, have we actually determined the cause for what initially caused their lungs to fail, and are we working towards reversal of that? Are they maintaining adequate oxygenations without a significant amount of support from the ventilator? Are they stable hemodynamically? Have we resolved any sort of extreme metabolic or respiratory acid-base disturbances? Do they have a appropriate hemoglobin? And are they able to protect their own airway if I extubate them? Are they able to participate and follow commands or show some sort of meaningful mentation that demonstrates to me that they'll be able to protect their own airway? And then once the patient meets these types of criteria, we can begin to consider a spontaneous breathing trial. Bear in mind that a spontaneous breathing trial doesn't necessarily require a physician order. At our institution, it's been discussed that the respiratory therapist can initiate a spontaneous breathing trial in the morning if the patient has been determined to be safe to undergo an SBT, and then that can be available for consideration during morning ICU rounds. There's multiple ways to perform a spontaneous breathing trial. The way that I've seen most commonly at our institution is to use a pressure support mode at a low pressure to begin to overcome the resistance of that ventilator tubing that the patient's not going to experience once they're extubated. The other way that it can be done is it can be performed using a TP circuit, which provides oxygenation but not ventilatory support. I actually have not seen that before, but you will read about that. And then there's a variety of predictors of success. So there's some physiologic variables, which really boils down to if a patient is having an SBT, are they pulling appropriate tidal volumes? And are they tachypnic or are they having appropriate respirations? Are they able to draw in enough volume to be able to support themselves without the assistance of the vent is really the key point here. And then there's some other indices that have been developed to help support or provide evidence that a patient may do well on expiration or extubation. One of those that you'll hear commonly about is the Rapid Shallow Breathing Index, which is a 1-minute trial of unassisted breathing with a PEEP and pressure support of 0. At the end of 1 minute, the average respiratory rate's divided by the average tidal volume, and that's used to obtain the RISB score. And a RISB less than 105 has been found to be predictive of successful extubation. You'll also hear some other things like a cuff leak test, which should be performed for patients at risk for post-extubation stridor. And these will help give you some information about if a patient develops this after extubation. It may give you some information as to whether or not they might be a difficult airway, and it'll help you prepare for that reintubation. But my patient doesn't meet all of these criteria. As I mentioned before, bear in mind that none of these indices are perfect predictors of successful extubation. And if all of your patients are always meeting all of your criteria, you probably aren't being aggressive enough in determining when a patient's ready to extubate. And you'll have patients who are ventilated for longer than they maybe need because they're not meeting all of your benchmarks. So there is some amount of allowable reintubation rate that demonstrates that you're giving patients a chance to breathe on their own effectively. So those are all of the learning points that I had today. We're just going to briefly review what we talked about. So we talked about the two types of ventilation, pressure control and volume control. We talked about some common modes of ventilation. And the ones that I want everyone to remember are assist control and SIMV, and how those modes are not inflexible. We can change them as the patient clinically betters. We talked about some of the physiologic and pathophysiologic consequences of ventilation as well in that discussion. We discussed some factors that contribute to abnormal pulmonary physiology post-op and who's at increased risk for that. So we talked about some intrinsic factors like lung disease, so COPD or asthma. We talked about things that may be iatrogenic, so volume overload from fluid resuscitation in the OR. We very briefly touched on when mechanical ventilation is indicated. And then we walked through a troubleshooting algorithm for when our patient's not doing well when they're on the vent. And I suggested some immediate mechanical ventilation settings to start a patient on, recalling that this is a moving target and we're going to be changing those settings depending on the patient's clinical status. We talked about recognizing esophageal intubation and why end-tidal CO2 is so important immediately after intubating and in evaluating if we have appropriate tube placement. And our finals, we talked about what's involved in weaning for mechanical ventilation. So we need to have worked towards treating the underlying cause of what caused them to go into respiratory failure in the first place. We want them to be stable from a hemodynamic standpoint and to have appropriate oxygenation off of the vent. We also talked about some of the predictive indices. Are they pulling appropriate tidal volumes, and are they having an adequate respiratory rate? We talked about some of the other indices like a RISB score. So at that, these are just some of the resources that helped me pull together this talk, and a little text box at the bottom, especially for the new interns. I'm a huge fan of the ICU book. It takes a really complicated series of topics and I think approaches them in a very approachable and conversational way. University of Maryland has some great videos if you're a video person. My personal favorite is the CRT video, which I've seen many times. And then the SCCM videos, I think you need a license for, but they helped me quite a bit at the beginning of last year. So at that point, I'll conclude the talk.
This is Dr. J, and Dr. Carpenter, I'd like to commend you, and what a great talk, and also a very warm welcome on July 1st. It's a great day to have this talk, starting off a new year, and to all the newly minted second years. As I discussed with you, Dr. Carpenter, if you just look backwards now and look at the incoming class of interns, you realize how far you've come in one brief year. And to the incoming interns, welcome. It is a daunting task and journey that you're on, but it's one we fully welcome you to with our full support. And if you don't feel a little bit overwhelmed on July 1st, you're probably not a human being, but we welcome you and we're really glad to have you here. That was a great talk. I just have 4 basic quick points I want to add and emphasize on what is a really great didactic exercise. Dr. Carpenter pointed out, again, if you're kind of overwhelmed by setting a ventilator, it's really 2 and 2. There's 2 knobs for oxygenation, 2 knobs for ventilation, PEEP and FiO2, rate and tidal volume. With respect to oxygenation, as a patient, if a patient is hypoxemic and you need to increase the oxygen concentration, one of the things I would commend to you is that there's actually 2 well-respected algorithms of how you increase both PEEP and FiO2 so that we don't come up with all sorts of various combinations. Oxygen is a toxic drug. PEEP helps us minimize the amount of oxygen we have to use. There's a high PEEP table and a low PEEP table. Either one has been found to be equally effective. Not one is better than the other, but they do help guide us in being a little bit more objective. The third point to mention is probably the most frequent reason you're going to get called early in your internship to the ICU is for the patient, quote, fighting the vent. And when you arrive in the room, you'll hear all sorts of alarms going off, and you'll see a patient who's usually agitated. I would just remind or ask you to think that really patients don't fight the vent. When a patient is struggling and the alarms are going off, it invariably means that the ventilator is not able to assist or be there to help the patient do what they've been doing for all their lives and what we've been doing through evolution, which is breathe physiologically. Patients don't fight vents. Vents just don't understand how to interact with patients correctly. So at that point, usually sit back, take 2 steps back, and try to figure out how to synchronize the patient so that they're not struggling or the ventilator is not struggling to work with them. And then finally, as was mentioned, patients, there are ways to get a reasonably good prediction if a patient can tolerate extubation, as mentioned, the spontaneous breathing trial. You will probably get called once or twice this year for a patient who met all the criterion, and then very rapidly after they were extubated, you get called back to the bedside because the patient's struggling. The one thing we can't reliably predict despite any kind of testing is the patient who has laryngeal edema once the endotracheal tube is pulled. If you are called for a rapid reintubation after extubation, I would just remind you that's probably the patient who's going to have some edematous cords who might be a more difficult reintubation. So that's particularly the time that I'm going to be calling for help, make sure I have all my airway adjuncts and maybe have some senior hands to help me do that difficult intubation. So with that, I'll turn it over to any questions if there are some, or it looks to be like almost perfectly timed to be 30 minutes. And again, Dr. Carpenter, that was a superb presentation.
Okay, sounds like no questions. If anyone has any questions that they want to ask offline, please feel free to come find me.
All right, thank you. Have a good day.